So
Okay.
next we have Sandro Mattioli. He is very famous surgeon, professor of surgery at the Alma Mater Studiorum, University of Bologna. He's the chairman of the Division of Thoracic Surgery. He's got a wealth of experience in surgical myotomy, and as you can see, the topic here is really quite unique. It's the data from 65 years long follow-up program. So we are really looking forward to that. Professor Mattioli is your podium.
Okay.
Okay, thank you very much. Do you hear me? Do you hear me?
Yes, very well.
Okay, I thank Marco, because who doesn't know the past doesn't know the real point of life. I will show you what is the real point of life. I'll tell you what is going on, and you will understand what the discussion will be after my presentation. So this slide was showed at the first ISDE Congress in Rome, 1980. Pay attention, please. We had operated upon in our group 83 abdominal long myotomies with 13 Lorta-Jacob anti-reflux procedures, which look like that dream proposed by Naue. That Lorta-Jacob operation was totally useless, and with the long abdominal traditional Western myotomy, we had 9.6 dysphagia percent and 22% of reflux esophagitis. One nurse died for a peptic ulcer perforated in the aorta. So we switched from that long myotomy into the Ellis short transthoracic myotomy. So this is history. Marco, that was published before. 30 transthoracic Ellis myotomy, and we had 23% dysphagia, and the disaster, 21% reflux esophagitis. What? That is honor to Dorothea Lieberman-Meffert. This is her paper, Gastroenterology 79. When you talk about sling and U fibers, you must know, not just talk. This is the U fibers, this is the sling, and this is the abdominal sphincter. I have published in Annals 1993 a paper. If you do not divide here, dysphagia still remains, as it was clear with the Alice operation and Marcos and Pellegrini experience. So that is the past. Don't make again, please, mistakes. So for this reason, because of the failure of the long abdominal myotomy without anti-reflux and the failure of the short myotomy, I did propose at the esophageal surgeons, the Heller-Dor, because it was proposed in Rome, 1980, 40 years ago, the first ISDE Congress. What is the physiology of this operation? A long U fibers division with 5 centimeters of esophagus and not a piece of fundus against the myotomy, but a full door covering the whole surface of the myotomy, avoiding, for example, visceral to make a scar against the myotomy. This is real surgery, not dream. So the publications I have done there, so I did show the video in San Francisco, 1981. Marco, Carlos was there. In 1973, we started a protocol. We reviewed patient operated upon since 1955, and it is still working. Okay? Clinical interview, barium swallow, manometry, endoscopy. We quit manometry after the second control and go on. This is our program. Now, pay attention, please. So this is the semi-quantitative scales we have been using for 40 years to evaluate results. When I say D0, absence of symptoms, the patient is symptom-free, period. Exactly for dysphagia and reflux. Look after esophagitis, because we must not joke with esophagitis. For us, R1 is only hyperemia plus the Ismail-Beigi pathological data. I think that 99% today doesn't know what the Ismail-Beigi classification is, but that means that for us R1 is just threatening. And another point, R2 is only one erosion. So it is different than saying severe Los Angeles CND. So when I had one erosion, for me, the result was poor. And this is the full result with the combined evaluation. Now, cases. Abdominal, no reflux, no anti-reflux procedure. 33.8% reflux esophagitis, pay attention. 11.3% mild, only reddening. I have scoped all those patients for 40 years. A2 and my gastroenterologist, of course. A2, A3, 22.5%. The Banchialis operation, 36.6% reflux, A1 13.3%, 23% A2, A3. So the message is the limited myotomies are disaster. We cannot, anybody, I have done 600 intraoperative manometries. Look at my paper in the annals. Even with the intraoperative manometry, you cannot trim the division just to have not too much reflux. So this is the Heller-Dor, open and laparoscopic. E1 3.4%, E2, E3 5.3%, follow-up 193 months. 193 months, the median. So what is very interesting, and we must not joke on the cards, E1, 24 patients, E2, erosion or ulcer, or 41 patients. No patient with E1 esophagitis developed Barrett's. This is a new information. Okay, so we must focus only with patients having erosive or ulcerative esophagitis, but erosive must be severe. Okay, don't joke with numbers, please. Interesting, post-myotomy severe GER group, 41 cases. Okay, what did it last to have reflux esophagitis since myotomy? Median 75 months, so we scoped the patients every year and after every 3 years. So we know exactly what did happen, okay? Median 75 months to get esophagitis, but, so a long time to get esophagitis, but a short time to get the Barrett's, 112 months, and a reasonably short time to get mild moderate dysplasia, a long time to get cancer. Follow-up period, a life. So we have matched those 41 cases with 81 cases of primary gastroesophageal reflux disease. No doubt that Barrett's and dysplasia run much faster in achalasia than in patients having normal peristalsis, which is fairly obvious. Risk of adenocarcinoma, 290 more times after 20 years of reflux. And look at this Heller-Dor result. Marco, you did not put my JCTVS paper in your review, in your meta-analysis. Those data were exactly like those. So look at the laparotomy and laparoscopy. The follow-up is 95-month laparoscopy. Look at the laparoscopy. The outcome is excellent, 80%, so poor, 4.2%. Clinical interview, barium swallow, endoscopy, so no doubt. And look after esophagitis. E3, 1.8%, E2, 1.2%. This is the result of a good, reasonably good surgeon. So, I will discuss, ask to have the room to discuss the type 3 achalasias, what we call the vigorous achalasia or diffuse spasm, because I can transfer to you the results of the long myotomies by Robert Anderson from Toronto, and I will tell you what does it mean. And I can transfer you that piece of apposition of the fundus against the myotomy is just nothing. It cannot be an anti-reflux procedure. Look after all the paper published. It is written in the past on pathophysiology of fundoplications. And I think that this data on cancer and dysplasia should review and reconsider the use of POEM. Thank you very much, boys.
Thank you, Sandro. Very interesting. Obviously, you know, reflux, Barrett's, and even cancer is something that we should keep an eye on.